Next is the right subcostal margin scan. Use this procedure to observe the right hepatic lobe, gallbladder, bile duct, and right kidney. Scan by slowly sliding the probe along the costal margin and tilting it. Repeat the motion several times. When you want to obtain a clearer image, have the patient do abdominal breathing and have him breathe in and then hold his breath. This is because the liver is shifted below the costal margin and the acoustic window is formed. In the liver, the portal vein and the hepatic vein can be seen. The portal vein appears to be complexly bifurcated with edges. The hepatic vein is often not edged and runs radially, with the inferior vena cava as the center. The inferior vena cava is almost perpendicular to the portal vein. This procedure allows us to observe the region perfectly from the right hepatic lobe to the right kidney. Check for tumors in the liver, abnormalities in the parenchymal echo, and dilatation of the intrahepatic bile duct, the diameter of the hepatic vein, and the portal vein. On the border between the liver and right kidney, or Morrison's pouch, is where ascites tends to develop. Therefore, observe this region carefully. Compare the echo level of the hepatic and renal parenchyma. In a normal case, they return echoes with almost the same level. The fatty liver includes a brighter area produced by the echo from the hepatic parenchyma. This deviation in echo levels is referred to as hepatorenal contrast. This is a fatty liver of mild severity. The hepatic fine grains, the so-called bright liver. The deep region is a hypoechoic area because the echo is attenuated by fatty drops. The intrahepatic vessels are narrow and ambiguous. In terms of the hepatorenal contrast, the echo from the hepatic parenchyma is clearly stronger and positive. For differential diagnosis of the fatty liver, both the hepatorenal contrast and the hepatosplenic contrast should be positive. In the images of the left portal vein, characterized by its key shape, the left hepatic duct is seen on the horizontal abdominal wall side. Normally, the hepatic duct is smaller than 4 mm in diameter. If dilatation occurs, the hepatic duct appears to have the same lumen as the portal vein that runs in parallel. This finding is referred to as the parallel channel sign. If a calculus, carcinoma, or other occlusion develops in the inferior bile duct, the left hepatic duct is the first to become dilated. Therefore, it must be evaluated in depth to differentiate obstructive jaundice. The gallbladder has a pear shape and appears on the screen in the area extending leftward from the horizontal part of the portal vein. Assess the thickness of the gallbladder wall and check for the presence of foreign objects in the lumen. This is a gallbladder with a slightly thick wall. The wall is not thickened in the area from the cervix to the septum, but it is thickened by 3 mm to 4 mm in the area from the septum to the bottom, presenting a 3-layer structure. This is a case of gallstones. A gallstone about 4 mm across is seen at the cervix of a gallbladder. A gallstone reflects much ultrasound, presenting a white image. A dark, no echo area appears behind a gallstone. This area is called an acoustic shadow, which is helpful for diagnosis of a gallstone. Some patients have a number of small stones, as shown in this image. This is a swollen gallbladder. Inside the gallbladder, you see a liquid surface-forming debris image. At the bottom of the gallbladder, you see a stone 3 centimeters across with the acoustic shadow. When a patient is told to change the position to the left lateral position with the probe kept in contact with the body surface, a gallstone is often seen falling in the gallbladder. This is effective information to differentiate a gallstone from a polyp in the gallbladder. This is a polyp in the gallbladder. On the wall of the gallbladder, a 3 by 5 millimeter polyp is seen. On the gallbladder bottom, you can see several polyps of 1 to 2 millimeters inside. If you cannot detect the gallbladder quickly, instruct your patient to do abdominal breathing. In a lean patient, the gallbladder may be located in the right side of the abdomen behind the front part of the right kidney or in the pelvic cavity. In an obese patient or a patient with a large amount of intestinal gas, this procedure may fail to detect the gallbladder. In this case, use the right intercostal scanning technique and scan the intercostal space between the 6th and 7th above the normal scan. That is to say, in a lean patient, the gallbladder is located lower than normally, while that of an obese patient is located higher. Bear this in mind, and you will be able to detect the gallbladder rather quickly. Press firmly on the probe, then lift the probe tip in such a way that the probe surface will be in parallel with the abdominal wall surface. This scooping technique will allow you to observe the deep area of the right hepatic lobe and the hepatic dome adjacent to the diaphragm. Hepatoma is sometimes detected in this region.